Hello, everyone. Welcome to our Zoom meeting. Today we will have a couple of items in the agenda, some presentations, and we'll get some updates. Thank you. Dr. Ahmed and his team will be presenting today. Please go ahead when you are ready. Thank you. Do we have the team?
Hello, Dr. Nader. Can you hear me?
Yes, I can.
Yes, how are you doing, Doctor? Hope you are doing well.
I'm doing great. Thank you. How's things going for you?
Thanks so much. Can I start the meeting?
Yes, please. When you are ready, go ahead.
Yes.
Thank you.
Yes, I am ready. I am ready. Good morning, good afternoon, good evening, everyone. Welcome to today's meeting. My name is Ahmed Khalifa, and I am the leader of Team Canary 2, and I am happy and honored to be the moderator of today's meeting with Team Beige, and I want to thank them for their invitation. I will be moderating the day. We have a rich agenda today with topics ranging from practical clinical issues to communication skills, and we will finish with the project updates with Dr. Nader. Let's get started. Topic one today is about food disorders in older adults. Uh, Food problems are often overlooked in older adults, yet they have a huge impact on mobility, independence, and the quality of life. This presentation will shed light on a very practical clinical issue. It is a little bit large presentation, and it will be divided on three respected presenters, Dr. Ahmed, Dr. Mudathir, and Dr. Duaa. Dr. Ahmed, are you ready?
Hello, everyone. Do you hear me?
Yes, we can hear you clearly.
Yes, I
Are you
am.
ready?
Yes.
Can you share your screen?
Okay. Um, it's not, wait. Can you see my screen now?
Yes, we can see it.
Okay.
Please start, Doctor.
Today our presentation will be about food disorders in older adult. Okay. Our content today, we'll have an introduction. We talk a little bit about epidemiology and age-related food changes, common food problems in elderly, nail and skin disorders, and how to prevent and treat those disorders. When we think about aging and age-related problems, the first thing that come to mind usually about memory problems and neurological problems, but not usually the foot. Food problems are common, yet overlooked, even though they are very important. The feet are often the difference between dependency and independency, especially in older adults, and highly affect their quality of life. So in our presentation today, we are going to shine a light on the food disorders in older adults, because many of them can actually be managed effectively with conservative interventions. The evidence on this topic are limited, but it's likely that maintaining skin integrity, as we will talk about, my colleagues will talk about later, range of motion and muscle strength of the foot will assist older adults to remain active. Also, we'll talk about screening. all older adults should undergo regular screening to ensure they don't endure needlessly disabling foot pain. First, epidemiology. As we said, the reliable data on this topic are limited, but one hospital-based study by Crawford in 1995 found that foot problems rate are as high as 80% in older adults. In contrast, a community study by Greenberg in 1994 reported only 30 to 40% of foot problems. Another study by Burns and colleagues in 2002 showed that women are more likely to suffer from foot problems. Generally, the overall prevalence of foot problems increase with age. About the age-related foot changes, before we dive into the pathological disorders, we will look at some of the age-related physiologic changes. As people age, the skin of the foot become noticeably drier, less elastic, and the epidermis is grow thinner and less resilient. Sensory receptor also decline, which reduce the ability to detect touch and vibration. Circulation also changed with reduced arterial blood flow, increasing the risk of peripheral arterial disease and its complication, while venous return become less efficient as well. All of these changes create a vulnerable foundation that make older adults more prone to foot problem. Another important change is in foot flexibility and strength. Studies show that those in their 70s have noticeably less ability to point and invert their feet compared to people in their 30s. Muscle strength also decline. On average, older adults have 29% weaker toe plantar flexion, and this difference is even greater between the sexes. According to Endo and colleagues at 2002, older women can have 39% less strength in this muscle than older men. Ligaments aren't spared either. Over time, they lose elasticity, they become stiffer, especially the ones like a plantar calcaneonavicular ligament. All of these changes, less flexible joint, weaker muscle, stiffer ligament, create a foot that's more fragile and prone to injury, setting the stage for many of these disorders that my colleagues will discuss with you in the next few slides. Dr. Mudathir and Dr. Duaa. Are they here or not yet?
Okay, yes.
Okay.
Am I audible?
Yes.
Okay, would you please control the slides for me,
Okay.
Dr. Ab? Okay, so good evening, everybody. I'm Mudathir Omer, and I'm going to discuss with you common food problems or disorders in elderly. So first of all, we're going to divide these food problems to be easy. We're going to divide it into 4 categories. Number 1, you have nail disorders, skin disorders, structural food problems, and functional food problems. So we're going in detail. Next, please. Regarding nail problems, first topic we have onychosis, which is thickening and overgrowth of the nail, and it's a disorder of nail growth. It's not an infection. It's characterized by significant thickening, abnormal shape and curvature, also discoloration of the nail. The nail can turn into yellow or brown discoloration or brown color, and there will be no debris or accumulation beneath the nail. One of the most common causes of this condition, including aging due to decreased blood supply, and also trauma, peripheral arterial disease, psoriasis, and diabetes. In terms of management of this condition, no, the last slide. No, we can back, please. The first slide, onychosis, yeah. Okay, so we're going to give you a small talk about management of this condition, which includes debulking and thinning of the nail, and proper footwear, and good foot hygiene. Okay, next. Second condition regarding nail problems, we have onychocryptosis, which is ingrown of toenail, usually the big toe. Okay, when the edge of the toenail grows into the surrounding soft skin, and it is characterized by pain, tenderness, swelling, redness, and inflamed skin. Also, as this disease progresses, it can present with edema, worms, and even pus and bleeding. One of the most causes of this condition include improper nail priming or cutting, also improper footwear and trauma. In terms of management of this condition, we can use soaking of foot in a warm and soapy water, also lifting of the nail and placing a small piece of cotton under the nail. Also, the use of antiseptic solutions. Okay, next. Also, in nail problems, we have onychomycosis, which is a fungal infection of the nail and accounts for apparently 50% of all nail disorders, and it's caused by a fungal species like dermatophytes, like Trichophyton rubrum, also can be caused by candida and mold. It will present with nail discoloration, as you can see. The nail can turn into white or yellow or brown color. Also, there will be a thickening of the nail blade and accumulation of debris, which can lead to separation of the nail from the nail blade. Okay, next. In terms of studies and research, a study was done in Slovenia to check the effect of novel laser using long pulse GHD 1064 nanometer in the range of 35 to 40 joule per centimeter square, a spot size of 4 millimeter and bulk duration of 35 millimeters. The pulse rate was 1 Hz. The laser beam was applied to substantially the entire nail blade by incrementally moving the beam in a spiral pattern. After the entire nail blade was irradiated, the treatment was stopped for 2 minutes and repeated by covering the nail with 2 more additional passes. The result of this study concluded the beneficial effect on killing bacteria, which is the common cause for nail fungal growth. Okay. So that concludes nail problems. Now we're going to go through some skin problems. We have hyperkeratosis and xerosis. In hyperkeratosis, which is a condition indicated by thickening of the outer layer of the skin, the striatum corneum, it's caused by pressure or friction, or even in some genetic disorders. The patient will present with thick and rough skin, also can present with skin discoloration and change in skin texture. In terms of management of this condition, you have to remove the source of friction and also to use moisturizers and gentle exfoliation of this growth. Also, we can use medical therapy like vitamin A derivatives, cryotherapy, and laser therapy. Okay, next. Second topic in skin problems or disorders, we have xerosis, which is abnormally dry skin. It's mainly caused by environmental factors like low humidity or change in weather, like cold or hot weather. Also, aging can cause this condition. Also, dehydration and some medical conditions like eczema, diabetes, and malnutrition. The patient can present with rough textured skin. Also, can complain of itching, redness, fissures, and cracks. In terms of management of xerosis, the most important thing is moisturization of the skin. Also, we have to tell the patient that you must drink plenty of water in order to overcome any sort of dehydration. And in severe condition, we can use topical corticosteroids. Okay, next. The third category includes disorders. We have structural problems. like Halox valgus, Halox rigidus, Best lanus, and Best cavus. So Halox valgus, which is a bony palm that form on the joint at the base of the big toe, which indicate a misalignment of the metatarsophalangeal joint, and the big toe is going to deviate towards the second toe. Also, we have hallux rigidus, which is the degenerative arthritis of the second metatarsophalangeal joint. It's going to cause the stiffness of that joint. Best lanus, which is flattening of the arch of the foot, and best cavus, which is abnormally high arch of the foot. Treatment for structural foot problems involve footwear modification, splinting devices, and management of secondary infection with training. Next, please. Number 4, or the last category, in food disorders, we have a functional food problems. We can divide it into heel problems, mid-foot problem, or and forefoot problems. In heel problems, the most common complaint is pain. An older person may become more likely to develop heel pain due to the effect of aging on structure and function of plantar heel bed. In mid-foot problems, the most common cause is plantar fasciitis, osteoarthritis of the tenonavicular joint, and less common causes are dorsal tunnel syndrome and tibialis posterior dysfunction. For feet problems, the most common complaint also is pain, and we call it metatarsophalangia. It also can be secondary to motor neuroma and stress fracture. Next. So, in terms of studies, there is a systemic review was to identify and evaluate the evidence of effectiveness for treatment of plantar heel pain. 19 randomized trials involving 1,626 participants were included. There was conflicting evidence for the effectiveness of low-energy extracorporeal shockwave therapy in reducing night pain, resting pain, and pressure pain as a short term. There was limited evidence for the effectiveness of dorsiflexion night splints in reducing pain. So treatments that are used to reduce heel pain seem to bring only marginal gains over no treatment and control therapy, especially as expression exercise. So there is no difference or only marginal benefit from this sort of management. Next, please. Now we are going to talk about insensitive food or sensory neuropathy, which can be caused by various pathological conditions. These pathologies lead to decreased circulation and peripheral nerve integrity, resulting in various neurological complications and dermatological problems. Change associated with insensitive food include neuropathic change, especially sensory neuropathy or sensory. Okay, next. This risk classification or evaluation scale for sensory neuropathy or insensitive food. We have grades from 0 to 3, with 0 indicates that there is no loss of sensation, there is a loss of sensation only, and 1 indicates there is a loss of sensation with no deformity or any history of ulcers, and number 2 indicates loss of protective sensation with deformity, but there is no history of ulcer, and 3 indicate loss of protective sensation with history of ulcer. So this risk classification identifies the individuals most likely to benefit from protective footwear and education. Okay, next. In terms of clinical examination or clinical assessment of food, after taking a proper history, we're going to do clinical examination and assessment. Certain food problems may be associated with reduced functional capacity. Clinical examination of food for all geriatrics should be done at least once in 6 months. So the incidence of signs and symptoms in such assessment will be like within a population of median age 75 years, we have loss of superficial sensation in 10%, of that population, and there will be again 12 to 20%. Skin lesions, circulatory problems, vascular disorders, and ulcers is 1 to 5%, and eventually edema is going to be 11 to 15%. Next, annual examination of food. The aims of annual examination is to carry out systemic search for food problems, also to identify patients who are not able to carry out basic food care themselves, and also to look for any skin complications on the food or the functional incapacity related to a food problem. Also to prescribe an appropriate food wear or aesthetics for strong modification. Next. Now we're going to talk about physical examination. After taking a proper history, medical and surgical, which include medical and surgical history, also social and occupational status, we're going to do a full examination of food, which includes neurological examination and evaluation of fertility status or vascular examination, also circumferential measurement of food. Also, it's a part of physical examination of food. Also, we're going to do a brain assessment using different scales, and eventually footwear evaluation. We're going to discuss these steps of examination in detail. Next. In neurological examination of food, we're going to check for superficial sensation using 10 gram monofilament other than areas of hyperkeratosis. So we are going to skip areas of abnormalities like hyperkeratosis. Also, we're going to check for vibration using 24. Also, we're going to check for lower limb reflexes if there is any hypo or hyperreflexia. Also, the range of motion and joint mobility of ankle. Also, we're going to look for any sort of deformities and muscle strength testing. Also, with the balance, we're going to check the balance, standing balance, and dynamic balance by using different tests. Next. Number 2, circulatory examination or vascular examination. We're going to inspect for the color of the limb in dependent positions. Also, we're going to check for pulse, the popliteal, posterior tibialis, and dorsalis pedis pulses. Also, we have to check for temperature. If there is cold temperature, it may indicate there is vessel vascular disease. If there is hot temperature, it may indicate some sort of infections like cellulitis. Also, we have to check for capillary fill time. If it is normally less than 2 seconds, if it is more than that, it may indicate also gas pressure vascular disease. Next. As a part of physical examination of food, also we have to check for the circumferential measures of the food by using a non-stretch tape. The person should be standing, bearing equal weight on both feet, and the foot should be flat on the floor. And always we have to check these measures bilaterally in both feet. We have to check for calf circumference, ankle circumference, heel diagonal circumference, circumference of foot around the ball, and also circumference of foot around the arch, and eventually the length of the foot. Next. And the benefit of this circumferential measurement is to give the patient or to describe him the proper footwear, also functional capacity and labor presence on daily living activities. We have to look for history of force, mobility aids, if there is any mobility aid. Also check for standing balance and dynamic balance by using time get up and go test, and a functional foot indices tool. Okay, thank you. I'm going to stop here, and my colleague Dr. Duaa is going to continue this discussion. Thank you.
Hello, is my voice clear?
Yes.
Hello, good evening, everyone. This is Dr. Duaa Mahmoud, and today I will be talking about pediatric treatment. Preventive management is based on risk classification scheme. So patient at risk categories from 1 through 3 are given education sessions about food inspection, skincare, and selection of footwear. So patient in category 1, they may benefit from a shoe with a leather upper and a box and a toe box that accommodates the shape of foot. And those who are in category 2 to 3, those may need customized insoles and shoe modification appropriate for these for their deformities. So regarding shoe modification, I will be talking about this in the upcoming slides. For screening processes, those who belongs to risk 0, they only need one screening process per year, and those who are in risk 1, they need twice per year. Those who belong to risk 2, they need it every 3 months, and those who in the third category, they need a monthly screening. Next, please. So regarding skincare, doctors should recommend application of neutral pH cream or lotion so as to reduce the skin dryness. And for education, doctors also should recommend cutting certain ways of cutting their nails, inspecting food, and look for potential risk, in addition to choose suitable footwear. For pedicure techniques, there is no information on how pediatric treatment affect symptoms in elderly. However, professionals in working group observed that hypertrophied nail require specific tools. Regular care can ensure that hyperkeratosis or nail disorders do not cause pain and helps improve patients' quality of life. Next, please. And evidence for that is a study done to see the effectiveness of foot care education in podiatry on subjects with type 2 diabetes. So they made structured pre-test questionnaire that was given with which had 4 sessions related to food hygiene and diabetes. Each subject received face-to-face health education regarding self-care. So the conclusion of the study was food care education for diabetics in a primary care setting improves their food care practice and is likely to be effective in reducing the burden of diabetic foot ulcer. Next, please. Okay, regarding treatment of plantar ulcers, we have 2 types of casts. We have the TCC, which is total contact casting. And this is the first one. And the second one is walking cast. For the TCC, it is used for ulcers in general. And a note here is the initial cast should be changed within the first week to prevent injury due to an improper fitting that is result after the resolve of edema. For walking cast, this is specifically used in ulcers, in those who are diabetic or non-diabetic, and it helps in healing the ulcer by reducing plantar pressure, reducing the leg edema, and protecting affected area. So here, this picture is reflecting the walking cast. This is the shape of it. Next, please. Regarding the type of cast, we have the Bekele did a comparative study of removable and irremovable walking foot to total contact casting in offloading the neuropathic diabetic foot ulceration. So this results suggested that a walking foot was as effective and safe as TCC, which is total contact casting, in offloading the neuropathic diabetic foot ulceration, irrespective of the removability. So the better acceptability and lesser costs of a removable device may actually extend the possibility of providing adequate offloading. Next, please. Regarding the usage of orthotics in food disorder, well, measuring the clinical impact of food orthotics only occur in very few studies. And these studies, none of them had been done in elderly population. So most of them focus on adult. So orthotics in Seoul have been shown to have some clinical effect in specific disorders in adults. And there is only one published clinical trial about nail splints or toe splints in adults. So orthotic insoles have a therapeutic effect on the risk of ulcer recurrence in diabetics, and also in preventing the deformities of rheumatoid arthritis. And the preventive effect of this has no association with the usage of analgesics or functional effect. Next, please. In this picture, you can see the usage of nail brace could be made by titanium or steel. And it is used in case of excessive nail curvature so as to correct it. But here we have some contraindication for its use or its usage. For example, if you have fungal infection in the nail, or even you have a tumor in the soft tissue or in the toe, the bone of the toes, I mean. So it's contraindicated to be used the brace. Next, please. Regarding the usage of brace, which is a non-surgical procedure, and the Emirates procedure, we have a study here done by Hertz and his colleague. The brace was VHO Oswald brace. It's a new method of orthonexia with Emirates procedure. These two procedures were done in 41 patients, or the study, I mean, were done in 41 patients. 21 were in the brace group and 20 in the Emirates procedure group. So pain due to treatment was significantly lower in the brace group than in the Emirates procedure group. And the study concluded that patients in the brace group could wear regular shoes, again, without appreciable pain, much earlier than those in the Emirates procedure group. In the brace group, there were 4 recurrences, and one patient was still receiving treatment at the end of the follow-up, while only 3 recurrences were recorded in the Emirates procedure. But none of the patients in the brace group had to take time off from work, whereas in Emirates there were many. They took like average of 14.7 days. So brace treatment provide a good conservative alternative to operative procedures. Next, please. In these pictures, we have we can see the different splints. We have the bunion splints, tensionite splints, and toe splints. All these can help in toe deformities that could happen in rheumatoid arthritis. Next, please. Okay. In geriatric footwear, we have certain criteria regarding good fitting. We have 4. So the first one, shoe provided must be appropriate to the activity undertaken. Number 2, help reducing shear and shock. Number 3, assist in transfer of force from one part of foot to another during gait cycle and during stance. Number 4, shoes should not produce pain and discomfort. So fulfilling all these 4 criteria could help in, or could reflect the good fitting. Next, please. Okay, regarding shoe modification, we discussed this earlier. We said this shoe modification could be done in category 2 and 3 wrists. We have here the heel edge, the heel wedges, the medial and the lateral wedge. Regarding heel wedges, it's a type of insole or shoe modification that changes the angle of the heel. For the medial wedge, it is thicker on the inner medial side of the heel, and it is used to correct the pronated foot, a foot that rolls inward by encouraging the foot to roll outward. For the lateral wedge, a lateral wedge is thicker on the outer lateral side of the heel, and it's used to correct a supinated foot, a foot that rolls outward by encouraging the foot to roll inward. And for height of heel, this refers to altering the overall height of the heel of the shoe. And this can be done for various reasons, such as to shorten the Achilles tendon's length or to accommodate a limb length discrepancy. That's going to be discussed in the next slide. So next, please. Another way of shoe modification, we have sole wedges. And these are used to alter the angle of the foot within the shoe. And the diagram shown in the left side, you have the pedal part and the elastics, which suggest a modification to the insole or sole to provide cushioning and support. We also have metatarsal bars, and as it's shown in the picture at the left side, which is a raised strip of material placed behind the metatarsal heads, which is the ball of the foot. And it is used to relieve pressure on the forefoot and shift weight backward during walking. And for the last way of shoe modification, we have limb length accommodation. And this refers to modification made to compensate for difference in length of person's legs, limb length discrepancy. As we show here in the left, in the right side, sorry, we have these two images that reflect limb length discrepancy, with one shoe having a significantly thicker sole than the other. And this is a common way to level the hips and spine, which can help alleviate back pain and other issues caused by discrepancy. So next, please. And evidence for that is a study made by Burns and his colleague, surveyed the proportion of elderly people in a general rehabilitation ward wearing incorrectly sized shoes and to look for the presence of complication. The median age for his population were 82 and 65 patients were assessed. So among those patients, 6 had a history of diabetes, 11% had symptomatic peripheral vascular disease, 26% had sensory impairment, 15% had foot ulceration presence, and 47 patients had ill-fitting shoes. So incorrect shoe length was significantly associated with the presence of ulceration. That was the consequences of the improper sizing or the incorrect sizing. Next, please. So what do you think, guys, about preventing the foot problem? So from these studies, the prevalence of ill-fitting footwear in older people is very high, between 50 to 80%. And as we know in Burns' study, a lot of problems were linked to the improper sizing of the shoe or ill-fitting shoes. So as to prevent such problems, we can depend on regular pediatric treatment But in addition to that, strength and flexibility training can markedly improve mobility in older adults. However, role of strengthening foot muscles and maintaining range of motion in foot joints has received very little attention. So strength training may also play a role in slowing the progression of conditions such as hallux valgus and lesser digital deformity. Next, please. So to sum up, food problems are commonly overlooked problems that impairs physical functioning and reduce quality of life in older people. All older people should undergo screening once in 6 months. Food problems can be managed with conservative interventions, and although there is lack of literature, maintaining skin integrity, range of motion, and muscle strength of foot will assist older people to remain active. Thank you so much for your time, and I hope you get benefit from the presentation.
Thank you so much, Dr. Ahmed, Dr. Mudathir, Dr. Duaa. Thanks for the great detailed presentation. It has covered everything related to food disorders, starting from the different manifestations, the causes, including nails, skin, structures, the forefoot, midfoot, and hindfoot. Also, the diagnosis, the different treatment line. It covered everything, and also it reminds us how something as simple as foot care can play a vital role in preserving dignity and function in elderly patients. Thank you so much. And now we shift for the audience. If anyone has a question for the presenter. Any question, please? Do you have any questions? Okay, now we can shift to topic 2 today, which is about data visualization. In research, how we present data is just as important as the data itself. Clear visualization makes science more accessible and impactful. Today's presentation will explore this essential skill. Please welcome Dr. Kotouf Mubarak. You have the stage now.
Thank you, Dr. Ahmed, for presenting me. So can you hear me clearly?
Yes.
Okay, perfect. I'll just go ahead and share my screen. Hello, everyone, and it's nice to join you today. Just give me a second. Okay, and okay, is that clear?
Yes, it's clear.
Okay, perfect. So, hello everyone. Again, my name is Kotouf Mubarak, and today I'm going to be talking about data visualization and just like a small keyhole glimpse into the role that it has in medical research. This is a gigantic topic, so we'll just have just a glimpse into this wider of a topic. So what we will be talking about today is just the definition of data visualization in itself and the magnitude of the effect that it can have on research and the magnitude that it can have on policymakers and just changes in healthcare and changes in life itself. And the common types of data visualizations, the principles of effective data visualization, like I mentioned, the role that it can have in medical research, the ethical issues and pitfalls that can present as well. And we'll just have a small talk about the tools that are available at this time. So starting in, what is data visualization? Data visualization is the process of making qualitative or quantitative data trends more apparent and readable. So a picture tells 1,000 words. So once you, we're all guilty of this. Once you open up some type of research, after you go through the abstract, the first thing that you're going to go through is to see and look for the pictures. You're going to go ahead and look for the bar charts, you're going to look for the maps, you're going to look for the tables and everything that's just going to summarize and present you this data in a way that is understandable, in a way that is a common language between all of us clinicians, between all of us researchers to say. And the most important part of effective data visualization is choosing the right chart type. Research is important in itself, but we can all agree that even if you find a research topic that is quite justable to have, maybe something relating to public health, something that is going to have tremendous effects once you get to the bottom line of what you're trying to search. If you even succeed in collecting the data, going through all of the loopholes, then you analyze this data and you find such a tremendous knowledge, such an important finding that you can now use to recommend another thing to add to the literature. That is all important, but you cannot do all of this without effectively visualizing this data for the people that are going to make those types of decisions. And the data visualization itself, the main important thing is not the tool or the applications, the softwares that are existent. This is not just the main thing. The main thing is your understanding, your application of that knowledge into something that is going to relay exactly the message that you're trying to say. So this can make or break your research. So it plays a key function in informed decision making by supporting the data analysis. The insights extracted from the data visualizations are critical in advancing research and new discoveries. And researchers use these tools to display data in an interesting and informative way, while the data analytic tools focuses mainly in finding trends and patterns. So many of these tools nowadays, they analyze and visualize at the same time. But like I mentioned, the key is your understanding, the key is your application of this knowledge. So we'll just go and look into some of these data visualizations that are available, some of the common charts, some of the simplest ones that are existent. So the first one we'll talk about is the bar chart. Its primary purpose is to compare categories against each other. There's different variations, one of which is the simple bar chart, then the clustered, the stacked bar chart, and the 100% stacked bar chart. Each variation serves to deliver a different message. And like I mentioned, this is the main key point here today, is you knowing exactly what message that you want to deliver and exactly how to deliver this message. So we can see examples here at the screen. On your left, you can see an example that is showing different. It doesn't even matter exactly what the data is showing, but you can see it's pointing your eyes to look at something. It's telling you that there's the huge numbers, the bigger numbers are at the top, and then it's down there. It decreases as you go down, and then it also went a further step ahead by using some visual keys, by highlighting the colors of the main findings that they have discovered in their research, and they even use that in the title as well. So this is just all of it together is going to pull your eyes towards what they're trying to say. On the right of the screen, you'll see the clustered bar chart. This is when you're trying to add subgroups into your categories that you're trying to find, such as perhaps you're trying to talk about the prevalence of a virus in different areas, and then you're talking about the serotypes, the different serotypes of this virus in different areas. So this can be applied in many ways. The 100% stacked bar and the stacked bar, the difference is it's a key difference. So the stacked bar, the main focus is, you can see that we're focusing on the main of the total effect of those subgroups together. You can slightly see the effect of the different subgroups within each group, but that is shown more effectively using the 100% stacked bar. So again, it all plays into how you use these types of visualizations. The second one I'd like to mention is the column chart. The column chart is similar to the bar chart, but the main difference is that it's mainly used specifically when you're trying to convey a change over time. Useful again for comparison in groups, but whenever you have a change over time, this is the one that you want to go ahead and use. Again, subtypes are clustered, stacked, 100% stacked. These are just one of these subtypes, some of the subtypes, I'm sorry, but not all of the subtypes. So you can see here, this is the Harvard's endowment fund that fell last year. So they were trying to draw your attention into a certain finding that they're talking about. So you can see in 2021, that was the highest amount that they have received in their endowment fund, and then it dropped by the next year. So they're using arrows, they're using their title, being very clear about that. And it's also giving you another part of an information where you can see the trends across the year. It has been increasing up to 2008, and then there was a huge downfall in 2009. Again, very clear, very accurate, and very informative. And anyone can understand that. This is not just for someone who's, say, in the business industry, or if it was a medical research in the medical research. No, this is something that even the public can understand. These are the other types, like I mentioned, the 100% stack. You can see here that it's drawing our attention to the different subgroups within each group. We can see the different serotypes for the dengue virus across different areas in Africa. This is quite a recent study. I wanted to include it because we all know how dengue has been affecting our country. On the right side, you can see the clustered column chart as well, which is attacking different subgroups in relation to the whole groups. Okay. This is the stacked again. This is not the 100% stacked. This is the stacked only. So you can see that we can see some of the differences across the subgroups, but the main thing that this is drawing our attention to is the overall across the years. Again, how it plays, what you're picking to use to represent your data has the huge effect on how it's perceived by your reader. Okay, so, and this is the pie chart. The pie chart, I'm sure we're all very familiar with, but what I am also sure of is that many of us has failed to use it properly. Many people use it to compare groups, but that is quite disturbing for, like, the data does not come across as clearly. If you're using a bar or a column chart, that's where you can be accurate. But the pie chart, when you're using it to compare groups, it does not present as visually understanding for your reader. The most thing that you want to use it for is when you're trying to compare multiple values against the total. Because we all assume that a circle is 100%. That is something that it's just intuitive in your minds, in everyone's minds. So you just compare one of the values against the whole. Other variations of the pie charts are the donut chart, amongst others, such as, so one of which is called the sunburst chart. I believe many different variations for all of the mentioned charts. Okay, and the first one we'll talk about today is the line chart. This is useful for showcasing changes and patterns and trends over time, especially if you're having some sort of anomaly, an upward spike or a downward trends. This is when it can be quite helpful to use the line chart. This is one of the main ones that you can see used across medical research. The most other variations of it is the multiple line charts, where we're trying to compare multiple values. Sorry. The area chart, the stacked area chart, the 100% stacked area chart as well. This is the multiple line chart. Okay. And last of which, but not least, the scatter plot is used to illustrate a relationship between two variables. So again, one of the many commonly used ones in medical research as well. Another variation, such as the bubble chart, which introduces an extra variable where you control the size of the dot itself, and then you're going to introduce another extra variable to your data. So this is it correlates between the findings. Say, for example, you're trying to see the prevalence of vaccinations in different countries across Africa versus the prevalence of the disease that that vaccination was targeting across the country, which would have been negatively invariable. It would have been the connections between both of them. This is an example of the bubble chart. Again, correlations and increasing another variable. So these are just examples, one of the commonest ways that is used and the simplest as well. Each of these have different variations, and there are many other types that we'll talk a bit about again here today. But the principles is, like we mentioned, that the good data visualization theory and understanding transcends any of the tools. The best way to master this skill is through learning and practicing. This might seem quite easy. It might seem intuitive, and it might seem like, well, this is common sense. Obviously, I would use this if I'm trying to express a certain finding, and I would use that one if I'm trying to express another finding. But believe it or not, it is not. And it requires a strong grasp for you to know how to understand and apply each of these things fully. And these are just the simplest ones. Imagine if we're talking about another type of a timeline chart, or maybe like even a map or something like that. So you need to have a full grasp in order for you to apply this. And in order for you to apply this to send a clear message, to draw the reader's attentions into what you're trying to convey. This is, in a way, it's a form of visual art, and at times it's the first thing to grab your reader's attention. So it represents a vital way for you to deliver your message correctly. There are other methods, like I mentioned, such as tables, maps, illustrations, and timeline charts, and many, many, many more. The tables are mostly used to show precise values or multiple variables at a time, because sometimes when you're having multiple variables that you're trying to appreciate in a given data, and you use a scatter plot, then you'll just confuse the writer. It's too much of an information to view in a line chart or something like that. And yeah, tables are that is when they come in handy. Okay, this is an example of the map. Yeah, it's also given us the suspected dengue cases across Africa. Okay, so a clear message requires you to have both the appropriate chart and an accurate title to reach the reader as well. So like we mentioned, we gave an example before, like you will present your finding appropriately using the appropriate chart. You'll point that out using visual cues as well, using colors, using arrows and stuff like that. And then as well, that all wraps together with your clear title, because sometimes a title can also make or break this finding. The title should be as precise and as simple as to what you're trying to say, and it goes along perfectly with the chart that you've used. You remove the clutter from the title, you remove the clutter from the chart as well. Sometimes these visualizations can be too condensed, too much information is there, too much words that aren't even needed for that title to be there. And this is just, sometimes it might be unintentional due to lack of knowledge. Sometimes it can be intentional to confuse, to confabulate, to hide the flaws and the issues with your data and with your findings. So you need to avoid being misleading through data bias, and clarity and accuracy, like we've mentioned, are a must. Okay, so this is an example that is just displaying how much of an effect this can have in your research. When you look at this, it's going to tell you just the overall tree cells that have risen steadily since 2002, driven by the Khoisan cherry growth, which it is there, but it is not as clear if you're using a line graph. That is why choosing the right chart has this much effect in what you're trying to say. Okay, so now that we've tackled a bit about the data visualization, what is its role in medical research? So data visualization is one of the most effective ways to explain, communicate complex information, particularly in the context of biomedical data. The rapid increase in both the volume and complexity of biomedical data represents new challenges in effectively and accurately presenting these informations. So to meet these challenges, there's new visualization methods that are being developed, either to address emerging problems or to extract novel insights from the existing data types. And as innovations in data visualizations continue to evolve, they are set to transform how we understand and interact with biomedical information. So this makes visualization an essential component of modern biomedical research. And like I mentioned, this goes along with our knowledge and our understanding. So still, your intuition, your knowledge is going to come in with your practice. It's going to come in alongside these innovations of the new softwares that are being developed on how we can present and perceive and understand those data. So this overall, it guides the advances in medical research and the constant changes in guidelines that are using evidence-based medicine. This has been a cornerstone in medical decisions in times of uncertainty, especially during the COVID-19 pandemic, where they used the global dashboard in epidemiological studies, public health, clinical trials, and many, many, many more. It plays an important role in communication of medical research findings, not only to not only clinicians, policymakers, but the public as well. This is immensely important. So as someone who is in Sudan, who's reading a research that has been done in Brazil, that has been done in Congo, this is just a form of communications across the whole world. So needless to say, the proper use of these tools and methods is essential. It directly impacts the clarity, reliability, and effectiveness of biomedical research. Okay, so this importance and this impact, that is what's going to lead us into the ethical issues and the pitfalls that can occur. Because misleading visual representations, either unintentional or deliberate, it can lead to bias in readers such as clinicians and policymakers. And it has been found that some researchers, they do deliberately try to hide some of the unfavorable findings that in their data in order to get published, in order to advance in their careers as well. And it can be unintentional as well, which in my personal opinion, that is the worst of it all, because your ignorance and your lack of knowledge, lack of practice, which is our roles as clinicians and as researchers, you not being updated, you not understanding, you not practicing, this can lead to false informations getting out there. So you select other things that are also a common ethical issue, selectively showing the favorable data and omitting others, overcomplicating the visuals so you can hide the flaws or the important things. Again, this can be intentional or unintentional. So, and the effects can be catastrophic when data is not handled properly. We'll talk about some of the tools that are there. Like I mentioned, this is just like a simple glimpse into this vast whole world. The tools are commonly used in medical data visualizations. I keep mentioning medical data visualizations because data visualization plays a huge role in business. It plays a huge role in other aspects of our lives. But I just wanted to connect this effect with medical research. So one of those are Shiny, Python, Tableau, SPSS, Power BI, Spotfire, and many, many more. One of the commonest that I have found many research talking about is the Tableau. So, and research into comparing those different tools is available online, but the consensus is that each tool has its unique advantages and limitations. And while some tools are easier to use for certain features, most tools can create similar or comparable visualization outcomes. And each tool can prove more useful for certain use cases than others. So users should match their use case against the capabilities of the tools. So yeah, again and again, it comes back to your own decisions, your own knowledge while you apply those tools and those software applications. Okay, so what I wanted to get to for this session is to give just a brief look into this underrated and undermentioned topic. But the purpose is just to attract your attention so you can go and learn more, because this certainly have made me go and learn more about this, and just to pique your interest into looking further in regards to data visualizations and the catastrophic effects that it can have on medical research that is in modern medicine. Again, thank you so much for today. I hope that I have piqued your interest, and you can go ahead and look into that further. Thank you again so much.
Thank you so much, Dr. Kotouf, for this elegant presentation. You showed us how data visualization is so important thing. It's not just technical, but it is a useful mean to make research data accessible and impactful, and it is a mean or a bridge between research and understanding. Thank you so much for your elegant presentation. And if anyone has a question for Dr. Kotouf, please ask. Any questions? Any
I just want to
questions?
say that it was so informative. Thank you so much, Dr. Kotouf.
Thank you so much for that, Dr. Reem. I'm really glad that that's what I was going for, just for everyone to think more about this topic.
Any question or comment? Okay, thank you. Now we move to topic 3 for today. A rational approach to antibiotics in common infections. Antibiotic prescription is one of the commonest dilemma in our time. Overprescription of antibiotics in outpatient care and inpatient is a big problem, and the antibiotic resistance is one of the most pressing global health challenges. How to write antibiotic, how to treat different types of infection, and how to choose the correct antibiotic for each type of infection. A rational approach to prescribing antibiotics is crucial for both patient safety and public health. Please welcome Dr. Isra, Dr. Reem, and Dr. Matiyas for their presentation, and we will start with Dr. Isra.
Hello everyone. My name is Isra Idris. I will be presenting today the rational approach to antibiotic and common infection. A practical guide for IMG pursuing a U.S. internal medicine residency. This is a crucial topic because as a physician, our prescribing discussion is not only affect our patient, but also shape the broader challenge of antimicrobial resistance. So let's start it. So, as a discovery of the antibiotic start with penicillin, it was a revolution in medicine. And then the follow in chemotherapy, transplant, and surgery. Antibiotics are life-saving, but misuse of it can cause antimicrobial resistance. What we mean when we talk about stewardship, it means responsible use, like correct drug, dose, duration, and patient. As internal medicine residents or any physician in the US or any part of the world, we will frequently see a patient with infection. But especially here in the US, we are also expect to think about long-term consequence like resistant and C. difficile, and we have to like use it as responsible use. So the antibiotic development challenges, let's talk about it. In 1935 until 2003, there is like 14 new antibiotics class being discovered. Since 1989, 10 new antibiotic being discovered, only 2 novel targeted, which is daptomycin and linezolid. The WHO in 2021 approved 11 antibiotics. Only 2 new classes, the Miniparum, Vabrobactam, and the Lifamulin. Only 2 of them were new classes. Development of antibiotic is costly and risky and less profitable. That's why caused the innovation process to be slow. And the implication of the stewardship is essential. The global and clinical important. The antibiotic misuse is a global concern. Overpricing, resistance, and Clostridium difficile, and the other adverse event that will happen of misuse of antibiotic. As a physician, we have to manage the common infection and balance the urgency and the stewardship. US guidelines for evidence-based and narrow-spectrum therapy. The benefit and risk of antibiotic treat infection, strep pneumonia, sepsis, and so forth. They are life-saving in severe illnesses. The risk of misuse is adverse drug reaction, gut microbe distribution, like increased infection with Clostridium difficile, and accelerate antimicrobial resistance. That's why we have to do the stewardship and rational antibiotic use. We have to confirm the infection before prescribing, identify the likely pathogen, choose empiric therapy wisely, and tailor to culture resistant, use short effectiveness or effective duration, consider local resistant pattern. That's why we have to ask ourselves, always ask, is this truly an infection? And then what the pathogen are most likely? Should we cover it or should we give the patient empiric antibiotic? And the appropriate initial, but we have to always remember to use the narrow narrow antibiotic. Okay, so the importance of the stewardship. These are the principles that apply everywhere, but especially in the US hospital, where documentation is important. Narrowing therapy is not just a good medicine, it's be expected. The compact resistant, inappropriate prescribing, which the adverse, the antimicrobial resistant, and we have to put in mind, we have to prevent the harm, minimize toxicity, microbial distribution, and improve the outcome, faster recovery, fewer complications. The term antimicrobial stewardship optimizing the antibiotic use. The key of the stewardship practiced, narrow spectrum, we have to consider it more over broad spectrum. Avoiding just in case prescribing, collaborate with the pharmacist, and de-escalate when possible. Document indication, duration, and review plan in the EMR, which is the electronic medical record. And also we have to do implementation and of the best practice. The core element is commitment, leadership, action, which we have to choose the route, which is like IV, oral, and switch, tracking and reporting, education, clinical and patient, and also as well as a family. And the strategy for this is going to be the right drug, diagnose, dose, and duration, auditing and feedback, guideline, and best practice, and ongoing education and collaboration between physician, pharmacist, nurse, and infection control team. And with that, it's going to be the end of my presentation. I would love to thank Dr. Nader and my fellow colleague, and I truly appreciate the opportunity to share my presentation. And with that being said, I would like to hand over to my colleague to follow the next presentation. Thank you.
Thank you, Dr. Isra. This is Reem Ahmed. I'll be presenting the second part of rational approach to antibiotics in common infection. Please, next, Isra. Okay, so Dr. Isra already spoke about this topic or this matter being a global concern, and she already spoke about the resistance that comes from overprescribing antibiotics, and that we have to follow evidence-based practice so that we can decrease the magnitude or the burden of antibiotic misuse. Next, please. And she also spoke about the principles of rational antibiotic use, and she spoke about the stewardship of the antibiotic prescription. Yes, so I'm gonna start with the common infections. So starting by the upper respiratory tract infections. I don't know if all of us are Sudanese here, but I remember that in Sudan, the moment you feel sore throat or the moment you feel cough, you're going to get the azithromycin, which is the 3 taps, and that comes from a common misconception that every upper respiratory infection is bacterial, which is the exact opposite of the truth. Most of the upper respiratory infection is actually viral infection, and for viral infections, we only do supportive care, which is using which is hydrating, taking rest, and so and let's move to pharyngitis, and we're going to talk about sinusitis later. So we have a guideline or a graph in the next picture. Can we move to the next slide? Yes. So if we're going to talk about the management of pharyngitis, we first have to know about the center criteria, which is first fever. It's fever by history, so it doesn't have to be in examination. If the patient had or has fever, that's first criteria. Second one is tender lymphadenopathy. Third one is tonsillar exudates, and fourth one is absence of cough. This criteria is what we mean by pharyngitis. If the four of them are present, we immediately start empiric penicillin or amoxicillin. If I apologize in advance for my voice, I'm feeling a little under the weather today. Sorry. So as I said, if we have the fourth criteria of center criteria, that's pharyngitis, we start immediately the empiric antibiotic. If we have only one or we don't have any of the criteria at all, that goes for viral pharyngitis. So we're going to, as we said, we're going to use the supportive care. If 2 or 3 are only present, we do a rapid streptococcal antigen, and if it's positive, we immediately start penicillin or amoxicillin. And this comes from the risk of rheumatic fever because it's high in streptococcal pharyngitis. That's why even if the rapid streptococcal antigen test is negative, we confirm by throat culture. If it's positive, then it's streptococcal pharyngitis. We start the oral penicillin or amoxicillin. And if it's negative, we go for viral pharyngitis and we do the supportive care. So are you following so far?
Yes.
Okay, so as we said, the benefits of the 10 days of penicillin for streptococcal pharyngitis is not only to decrease the severity of the symptoms, but also to decrease the duration of the symptoms, preventing of the spread to close contacts, and most importantly, to prevent the serious outcome, which is rheumatic fever. So we have a question here. What's the next step in management for a child that presents with fever, pharyngitis, tonsillar exudates, and tender lymphadenopathy? So here, this is bacterial pharyngitis, and in children, we have to confirm first by rapid streptococcal antigen testing, and if it's positive, we immediately start amoxicillin. So that concludes our first part, which is the respiratory tract infections. We have not yet spoken about the sinusitis. So regarding the sinusitis, can we go back? Yes. We only treat if the symptoms are present for 10 days. And that's because we do have viral sinusitis. And the viral sinusitis, it has mild symptoms, like the patient is well appearing, only facial pain, and there is no fever or there is a low-grade fever, and it most commonly resolve in 5 to 10 days. So we don't have to treat with antibiotics. If the symptoms still present or persist for more than 10 days, that's by default bacterial, because how we define bacterial sinusitis is that sinusitis with fever present for more than 3 days, or the symptoms recur after initial improvement, or the symptoms persist for more than 10 days. So we only use antibiotics for sinusitis if the symptoms persist for more than 10 days, or if it's severe, because severe, that's by default bacterial pharyngitis, because for viral bacterial sinusitis, because viral sinusitis is mild. So the first line is amoxicillin clavulanic acid, or amoxicillin as we call it, for 5 to 10 days. So that's for the upper respiratory infections. Any questions so far? Okay, I assume it's a no. Let's go to the second infection. The second infection is urinary tract infection. So we all know that urinary tract infection is two-part. It's
Hello,
either...
doctor. Hello.
Yes.
I have a question regarding sinusitis. Is someone he has allergy from amoxicillin? What is the best treatment for that?
Yeah, so that's a good question. If we have any allergy to penicillin, we go for the second line, which is either the doxycycline or the fluoroquinolones as a Cipro. Does that answer your question?
Yes.
Thank you. So moving to urinary tract infections, we do have two types of urinary tract infections, either cystitis or pyelonephritis. What we mean by cystitis is only symptoms of dysuria, frequency and urgency, but we don't have the systemic symptoms of fever or flank pain. So for cystitis, if we have cystitis, which is uncomplicated UTI, we either use nitrophenolate for 3 days, trimethoprim sulfa for 3 days, or fosfomycin 1 dose. And if it's pyelonephritis, we use fluoroquinolones as in Cipro, or if it's inpatient, we use ceftriaxone injections. The other part, or the other type of urinary tract infection, which is quite common, is asymptomatic bacteriuria. And what we mean by asymptomatic bacteriuria is when we find more than 10 to the power 5 colony-forming unit of a single uropathogen in 2 clean cat urine specimens without symptoms. So we don't usually treat that kind of infection only in pregnancy or in radiologic surgeries, or if we have procedures like mucosal, like if we have procedures like TURP, and a patient has symptoms like mucosal bleeding, that's when we treat the asymptomatic bacteriuria. And we usually treat it as acute cystitis with either amoxicillin clavulanic acid for 5 to 7 days, fosfomycin single dose, or cefalexin for 5 to 7 days. And for pregnancy, we know that we can't use nitrophenolate in the first or the third trimester. We cannot use the sulfur drugs, and we cannot use the fluoroquinolones in pregnancy. That's why we only use either amoxicillin clavulanic acid, fosfomycin, or the single dose of fosfomycin, or the cephalexin. I'm sorry again. So, do you have any question regarding the urinary tract infections? Okay, let's move to pneumonia. Pneumonia is the infection of the lung, which leads to symptoms of fever, cough, dyspnea, and pleuritic chest pain. And on radiology, we see infiltrates. It's according to the type of pneumonia. If we have like low pneumonia, the infiltrates are only in one point of the lung or one lobe. If we have interstitial pneumonia, we have like bronchopneumonic pattern. So, but regardless, we have to use the CURB 65 guideline or the CURB 65 mnemonic to guide the hospitalization of pneumonia, because pneumonia can be a severe infection. So can we move to the next slide to know about the CURB 65? Okay, so as we said, it's a mnemonic. C stands for confusion. U is for urea if it's more than 20 milligram per deciliter, and the R is for respiration if the respiratory rate is more than 30 per minute. The B is for blood pressure if the blood pressure systolic is less than 90 or diastolic is less than 60, and the age is the 65 for the age if the age is more than or equal to 65. So if the CURB 65 is 0, the score is 0, that goes for the outpatient treatment because it has low mortality. And if it's 3 or more, especially if it's 5, this stands for or corresponds with severe pneumonia, and it has high mortality. That's why we need urgent inpatient admission. As we said, especially if the score is 4, we need ICU admission. If it's intermediate score or intermediate mortality, we go for inpatient treatment, not ICU, but inpatient floor treatment. And for the choice of antibiotic, can we go to the next slide? As we said, if the score is 0 or 1, this is outpatient treatment. For outpatient treatment, we give, if the patient is healthy, no comorbidities, no lung infections, that's lung infection, no cardiac issues, and no renal issues, we only give macrolides, as in azithromycin or doxycycline for outpatient management. And if the patient has comorbidities, we start by beta-lactam with the macrolide. Beta-lactam is penicillin, or cephalosporin if there is penicillin allergy, with macrolide. And the second line is fluoroquinolones. The respiratory fluoroquinolone that we use is levofloxacin. And if the score is 1 to 2, that's inpatient. So inpatient, but not ICU. We start by fluoroquinolone IV, and if that's the first line. The second line is beta-lactam with macrolide. And if the score is more than 3 or 4, we immediately admit, that's the word, we admit the patient to the ICU, and we either use IV injections of beta-lactam with macrolide or beta-lactam with fluoroquinolones. And we have to reassess the patient every 48 hours. So that concludes our part of pneumonia and antibiotic choice in pneumonia. Is there any question? So that concludes my part, and Dr. Matiyas will complete.
Hello, everybody. Do you hear my voice?
Yes.
Okay, thank you. So I would like to thank you for this opportunity, and I like to appreciate my fellow presenters for their nice presentation. Next slide, please. So my topic will be on, we'll start on the soft tissue infection. As you all know, soft tissue infection composed of a variety of infection. It started from the skin to deep down to the muscles. And for the time's sake, so I will present some most common soft tissue infection and the more clinically severe ones. So the first thing when we suspect soft tissue infection is we have to be sure that is it really an infection or is it an infection mimetic? So before we prescribe any antibiotics, we have to be sure that it is an infection. So for example, in the leg, a DVT can mimic an infection or a cellulitis in the leg. So we have to be sure that this is clearly an infection. So the hard thing is that it is the diagnosis is clinical. So other diagnostic tests like ultrasound and other radiologic investigations are usually not helpful in this case. So we have to be clinically sure that it is an infection. So if we are sure that this is an infection, so the next question we have to ask is antibiotic really necessary? Or if antibiotics is necessary, is this the only thing, or we have to call someone to involve in the management? For example, if it is necrotizing fasciitis or abscess, we have to contact with the surgical department because debridement and incision and drainage is more important than the antibiotics. So we have to be sure on that. So one of the common condition associated with soft tissue infection are the gas gangrenes. Gas gangrenes are usually caused by Clostridium preferens, and the first line antibiotics for this type of infection is IV penicillin plus clindamycin. Clindamycin used as an inhibitor for toxin release from the Clostridium preferens. So as with antibiotics, we have to also communicate with the surgical team, and surgical debridement is crucial. The next common condition associated with soft tissue infection is impetigo. So there are two types of impetigo. The non-bullous one is usually caused by Streptococcus pyogenes, and the bullous one is most commonly caused by Staph aureus. So based on the area of the skin involved and the systemic signs, we have to choose between topical treatment and oral treatment. So for impetigo non-bullous, we can use topical mupirocin creams, and also for more severe ones for the bullous ones. And if there is any systemic signs, we have to use the oral cephalexin or dicloxacillin. The other most common condition in soft tissue infection is eczema. So this is caused by group A Streptococcus mostly, and others are methicillin sensitive and methicillin resistant Staphylococcus aureus. So the first line antibiotics will be oral cephalexin, and Alternatively, we can use amoxicillin and carboxylic acid. So next slide. So one of the common soft tissue infection is cellulitis. So cellulitis can be purulent and non-purulent. Usually the purulent one is caused by Staphylococcus aureus, both the methicillin resistance and also the sensitive ones. And the non-purulent one is mostly caused by Streptococcus pyogenes. This is not a black and white rule, but most likely the purulent one is caused by Staphylococcus aureus, and the other one is caused by Streptococcus pyogenes. So for the non-purulent cellulitis, the first line antibiotics will be cephalexin and also anti-staphylococcal penicillins can be used, like dicloxacillin, and we can use amoxicillin with carboxynate. For the purulent one, we can use trimethoprim, sulfomethixazole, and as alternative, we can use doxycycline, and in severe case, we can also use linezolid. So the other one is erysipelas. Erysipelas is sometimes difficult to differentiate with cellulitis, but erysipelas usually have well-demarcated margins and also usually happen in nasolabial area and in susceptible individuals. It is caused by group A Streptococcus mostly, and we can use as a first-line treatment IV cefazolin, or as we all know that Streptococcus pyogenes are penicillin sensitive, so we can use oral penicillin V, and if penicillin allergy is a concern, we can use also clindamycin. The last and the one of the crucial soft tissue infection is necrotizing fasciitis. So this is usually polymicrobial, but the common culprits in this disorder is Streptococcus pyogenes and Clostridium preferens. So this is very critical soft tissue infection. So we have to be clinically suspicious, because in the first time, there may be no symptom related to this infection. So we have to be clinically suspicious, and the treatment as first-line antibiotics are the penicillin with tazobactam plus vancomycin and clindamycin. And as alternative, we can use carbapenem-based regimens. Next slide, please. So the next topic will be on diabetic foot infection. So concerning the diabetic foot infection is one of the most common complications of diabetes. So first of all, we have to make sure that it is an infection of the diabetic foot. So there may be an ulcer that is not infected, or there may be an morphological complication of diabetes that is not an infection. So we have to make sure that this diabetic foot is infected. After that, infection is confirmed. So we have to do a sterile probing, because if the sterile probe go easily to the bone, we have to suspect the osteomyelitis, and we have to make sure that the X-ray have the foot have an X-ray, because it will change the whole treatment process. So we have to make sure that after that, if we make sure it's an infection and it doesn't involve the bone, we have to contact with surgical teams, and also some culture should be taken from the wound, and superficial cultures are not recommended in diabetic foot infection, because it is polymicrobial, and we can see some bacteria in the culture that are not clinically important. So we have to do a deep culture, and we have to send them to the laboratories. So that it is, as I told you previously, it's a polymicrobial, and both anaerobes and gram negatives are also involved. In severe case, we can use vancomycin, piperacillin with tazobactam, and alternatively, we can use carbapenems and vancomycin. If it is a mild infection, usually caused by Streptococcus or methicillin-sensitive Staphylococcus aureus, we can use amoxicillin and calbucinate, or as alternative, we can use cephalexin. So we don't have to miss on the debridement part in addition to the antibiotics. Next slide, please. So the other concern is Clostridium difficile infection. So as we all know, Clostridium difficile infection is iatrogenic. Usually you have to suspect Clostridium difficile infection if these two conditions are met. If the patient have recent antibiotic use with new onset of diarrhea. If we have this combination, we have a strong suspicion of Clostridium difficile diarrhea. So these treatment guidelines will change every year, but as of 2024 guideline, the first line for first episodes of Clostridium difficile diarrhea is fidaxomicin, and oral vancomycin is a second alternative. But in conditions like if the first episode is severe, or if the first episode is fulminant, we can the first line will be oral vancomycin. So it will be changed to oral vancomycin. In case of recurrence, if it is a second recurrence, we can use the first treatment we use in the first episode, or we can use fidaxomicin as an initial treatment. But if it is recurrence more than 2 times, we have to consider vancomycin with fecal microbiota replacement. So we also have to avoid antimotility agents because they can predispose patients to toxic megacolon. As a preventive method for Clostridium difficile infection, we have to be careful on antibiotic prescribing, and we have to minimize the duration and the spectrum of the antibiotic therapy, and we have to isolate patients we have suspected or confirmed Clostridium difficile infection, and also we have to enforce hand hygiene. Next slide, please. So these are the high-risk antibiotics that are commonly associated with Clostridium difficile infection. So the most common one is clindamycin. It is a very high risk. The other ones are the fluoroquinolones, the ciprofloxacillin, levofloxacillin have high risk for Clostridium difficile infection. The other ones are the cephalosporin families. Next slide, please. So the next topic will be on culture-guided therapy. So as a principle, we have to obtain the culture before we introduce the antibiotic. So because it will alter the culture result, we have to take the culture before we start antibiotics. But this may not be feasible in some setups, because some patients may come in very severe condition, so that we have to start on antibiotics before we send some cultures. So we have to respect the rule, but it is not a black and white rule. So in some cases, we have to start antibiotics before sending the cultures. Common sources of cultures can be blood, urine, sputum, and wound swabs. So after starting antimicrobial therapy, we have to reassess after 48 or 72 hours. And also we have to revise the culture and sensitivity result, and we have to revise our treatment based on that. So one of the concepts is de-escalation therapy. What it means is we have to start on broad spectrum antibiotics, and based on the culture and the sensitivity result, we have to narrow our antibiotic regimen so that antibiotic resistance and also other complication cannot be arised. So why culture is important? You have to, because it's reduce unnecessary broad spectrum antibiotic use. It also minimize resistance development, and also it's improved patient outcome and safety. Next slide, please. So these are the common pitfalls to avoid on prescribing antibiotics. So because of patient concern or to be on the safe side as a physician, sometimes physician prescribe antibiotics for viral infection. This will affect the antibiotic stewardship, and ignoring renal dose adjustment. Some medication antibiotics need some renal dose adjustment. Sometimes physician will ignore that, so it is not a good practice. So we have to be cautious on renal dose adjustment. And after the culture result is arrived, we have to review and adjust our antibiotic regimen based on that. And there is also concern on overusing of fluoroquinolones, and also the duration of antibiotics. We have to stop antibiotics based on the clinical and also the duration of antibiotic need. So we have to review that, and if the patient is clinically improved and the timeline has also completed, we have to stop the antibiotics. Next slide, please. So as a final takeaway, we have to think critically before prescribing. We have to make sure that it's an infection, and if it's an infection, we have to at least be cautious that it is bacterial rather than others. So we have to know common bugs in common infections and common drugs that can cover them. And also we have to use local resistant data, so that before culture and sensitivity arrived, we have to prescribe the broad spectrum antibiotics, so that we have to make sure that a local resistance data is available, and we have to review that. We have to practice stewardship of antibiotics, and it will help us in our clinical residency and also on our clinical practice in the future. Next slide, please. So this is a case discussion. It's a 72 years old woman presented with product cough, fever, shortness of breath, and chest X-ray shows left lower lobe infiltrates. So she has no comorbidities, and oxygen saturation is 93% on room air. So the question will be, do we have to admit the patient, or do we have to treat her as outpatient? What empiric antibiotics we have to use, and for how long we have to treat her? So I will give this to the audiences. Anyone?
You can use CARE 65 if she has confusion or uremia. So we can, I think admit or
There is there is no confusion
yes.
or uremia, but she is 72 years old.
Respiratory rate is not more than 30.
Yeah.
Yes. So we can treat it her as outpatient.
Okay. So
And also oxygen saturation is okay.
Yeah, it's 93% on room air.
Yes. So we can give her like amoxicillin or amoxicillin. And I think the treatment for 7 to 10 days.
Okay. Does anyone have a different opinion?
Even though we don't have like a change in mental status, this is an old patient with shortness of breath, so it would be better to admit the patient at least to the wards.
Okay. If there is another opinion, Dr. Reem, as you presented the pneumonia part, can you say something about it?
Yes, so if we're going by the curve 65, we only have the age, which is more than 65. So we can treat the patient in the outpatient. And we can give levofloxacin or amoxicillin for 5 to 7 days. And that's what I think.
Okay, thank you. So
I think based on her age, which is more than 65, she is scoring 1 on curb score, and score 1 to 2 is better to be admitted to the hospital. Score 0 is for outpatient, score 1 to 2 is for inpatient management, especially for her age and the oxygen desaturation, and also the curb score, which is 1. So it's better to be admitted to the hospital. And to receive IV antibiotics like macrolide plus beta-lactam or levofloxacin single agent for about 1 to 2 weeks.
Thank you,
okay.
Doctor.
Thank you, Doctor. Based on the curve 65, she only have one criteria fulfilled, that is her age. Her age is 72 years old. So based on the figure Dr. Reem has shown us previously, it is better to admit the patient and start on IV antibiotics. Next slide, please. So this is another quiz. So which of the following is not an appropriate reason to prescribe an antibiotics? So A is positive urine culture in asymptomatic pregnant woman. B is sore throat with positive strep test. C is cough for 2 days with clear lungs and normal vitals. And D is cellulitis with erythema and tenderness. So some, okay. I was seeing the chats. Most of you had said C, that is the correct answer. So positive urine culture in asymptomatic pregnant is one of the indication to start on antibiotics. Sore throat with positive strep test needs an antibiotics, and also cellulitis with erythema and tenderness also needs an antibiotics. The correct answer will be C. So if you have any question, you can forward, and we are here to respond, I think.
One question I have, can you hear me?
Yeah, I can hear you.
Okay, one question I have is, if we have a patient that we've seen X-ray findings consistent with bacterial pneumonia, and we are treating them, but is there any like specific time where we have to do a repeat X-ray, or is there a place to follow the patients with repeat X-ray? Can you say something about that?
Okay, I think based on my references and my reading, I don't think there is there is way to do a repeat X-ray, except if there is no improvement after we start on the treatment, and we expect improvement after 5 to 7 days. So if the patient is not improved in that duration, and we suspected a complication like empyema or other complication related to the pneumonia, we can have repeated X-ray. Otherwise, if the patient is improving and there is no, I think there is no clear day to repeat X-ray.
Well, we have to assess the patient clinically every 48 hours.
Okay, thank you.
Okay. Thank you.
I want to add something. If you are asking about when to detect improvement on shift radiograph,
Okay.
either chest X-ray or CT chest, it needs at least 14 days, 14 to 30 days to show improvement. Maybe the patient has already improved clinically within 7 days, but if you repeat the imaging, it will mostly stay the same. But to detect radiographic improvement, you need at least 14 days up to 30 days from the start of infection.
Yes, as Dr. Ahmed said, we have to assess after starting the antibiotics, we have to assess the patient clinically. If the patient is not clinically improved, we can have an X-ray repeated, but the X-ray changes will need at least 14 days to resolve after antibiotics. So if we didn't suspect any complication, repeating an X-ray based on duration is not recommended. Okay, if there is no question, thank you for this opportunity, and we will wind our topic.
Thank you so much, Dr. Isra, Dr. Reem, and Dr. Matiyas for this excellent detailed presentation. It was so interactive, covered most of the aspects needed for us as practitioners for the use of empirical antibiotics. This is an important reminder that every prescription can heal the patient, can worsen the patient, and can also contribute to increased resistance to every prescription is also a huge responsibility. As I say thank you, let's shift to the next topic, topic 4, which is about how to say thank you. Gratitude may sound simple, but how we express it can shape relationships, teamwork, and even leadership. The presentation offers us a chance to reflect on something we often take for granted. Please welcome Dr. Nuha and Dr. Nipa for their presentation.
Yes, Ahmed, what you said is true. Hello, everyone, and thank you all for having us today. I'm Dr. Nuha Yassien. and alongside Dr. Nipa. We are really delighted to be here with the telegeriatric team and, of course, Dr. Nadir. Today, we want to share a small but truly powerful topic, the simple act of saying thank you and why it matters so much in our relationships with our patients. It might seem like just a small courtesy, but it's actually a vital part of building trust and strengthening the patient-physician relationship. Gratitude can help patients feel valued, respected, and heard, something that can ease their anxiety and encourage cooperation in their care. In geriatric, especially where patients may face loneliness, fear, or a sense of dependence, a heartfelt thank you can remind them of their dignity and their importance. So, in the next few minutes, Dr. Nipa will explore how this simple phrase can transform the way we connect with our patients and how incorporating it intentionally can enrich both their experience and ours as healthcare provider. Thank you so much of all. And Dr. Nipa, share your screen.
Thank you so much, Dr. Nuha, for that wonderful introduction. Today, we are going to be discussing a very important topic, which is about expressing gratitude. It's a simple practice, like we've mentioned, that measurably strengthens care, right? Thanking our patients. We'll cover when and how to express gratitude, what to say, what to do, and how to stay within ethical boundaries. Our goal is practical. We are going to try to give you phrases, gestures, and workflows you can use on your next shift to build trust, improve adherence, and make visits feel more human. So with your attention, I'm going to shift to my shared screen. Okay, so the first slide, which is going to be about a comprehensive guide to building stronger therapeutic relationships through meaningful expressions of gratitude. And why thanking patients matters, because what we essentially know, it enhances relationships. It enhances the trust and respect between patient and physician, and also has better outcomes in prognosis. So in case of enhanced relationships, patients' gratitude improves relationships quality and builds lasting loyalty between physician and patient. It also creates mutual respect and trust, which are essential foundations for effective medical care. And when you enhance relationships and you build trust and respect, it leads to better outcomes in patient care. So it enhances patient satisfaction and significantly improves adherence to treatment plans. When is the best time to express thanks? Well, it can be expressed during key milestones, during patient engagement, and vulnerable moments. The key milestones are after diagnoses, treatment completion, successful follow-ups, or recovery achievements. And during patient engagement. So this is when patient shows active participation, when they ask questions or provide valuable feedback. And then also during vulnerable moments. This is during emotionally challenging conversations, difficult diagnoses, or times requiring patient courage. So there's many ways to express thanks. So the verbal ways of expressing thanks is through being simple and sincere. Like, for example, thank you for trusting me with your care, or I appreciate your openness during our discussion. It can also be personalized recognition. Your dedication to following the treatment plan has made such a difference in your progress. And we can also use empathetic language when expressing thanks. For example, thank you for sharing something so personal with me. This shows genuine appreciation for patient vulnerability. There are some actions that also show gratitude, right? It doesn't always have to be verbal. So, for example, follow-up communication, educational resources, and time and preference respect. So, for example, why during follow-up communication? So this is during proactive calls or messages, checking on patient well-being between appointments. So this is a very simple, way to express gratitude. And then educational resources, providing helpful materials, information pamphlets, or relevant health resources. And then time and preference respect. honoring appointment schedules, accommodating patients' needs during visits are also actions that help to show gratitude. So these are all simple ways of showing gratitude without verbalizing, right? Okay, so next we're going to talk about nonverbal expressions of gratitude. So, for example, when you're having a conversation, you keep a warm eye contact, attentive body language. Our body language matters a lot, and thoughtful gestures. So, warm eye contact, so this includes genuine smiles and attentive eye contact that convey respect and sincere appreciation for the patient. So, avoid using your phones when you're having a conversation with your patient. Give your patient the time that they need. And then attentive body language, often open posture, leaning in slightly, and fully present body language that signals deep care and respect. And then also thoughtful gestures, handwritten notes, personalized cards, or small meaningful tokens that show extra consideration. Now we're going to talk about the role that gratitude plays in relationship building. It enhances collaboration, it improves the patient outcomes, and also it builds a covenant of trust. So enhanced collaboration, this encourages ongoing patient engagement and active participation in their healthcare journey. And this will also improve outcomes because the follow-up rates will be high, right? Your patient will want to come to you and want to adhere to treatment, right? And this will lead to our next point, which is improve outcomes. It reduces patient anxiety, stress, leading to measurably better health outcomes and recovery because your patient feels comfortable coming to you, right? They feel heard. Next, this will ultimately lead to the build of covenant of trust. This creates the foundational covenant of trust that is essential to effective medical practice and ultimately build the patient-physician relationship. However, expressing gratitude, everything is good, right? But at the same time, we have to learn to maintain professional ethics, right? While expressing thanks. So this includes gift acceptance guidelines. So accepts gifts thoughtfully and carefully, avoid any potential conflicts of interest that could compromise care, right? Number one thing that we definitely want to avoid is favoritism. Fairness and confidentiality, maintain absolute fairness, strict confidentiality, standards in all patient interaction, expressions of gratitude. Professional boundaries, direct fundraising or solicitation from patients is ethically discouraged and should be avoided entirely. Yes, exactly. So proper boundaries are very essential to having a really good patient-physician relationship. Remember, gratitude should always enhance the therapeutic relationship without compromising professional ethics or patient trust. So there now coming to the conclusion, we want to give you guys practical tips like natural integration, cultural sensitivity, and authentic connection, right? That will further enhance Thanksgiving. So natural integration includes weave gratitude seamlessly into conversations rather than forcing formal acknowledgement, right? Don't make it uncomfortable. Cultural sensitivity, tailor your expressions of thanks to individual patient preferences, cultural backgrounds, and communication styles. And then authentic connection. Use gratitude as a tool to foster genuine connection and build meaningful rapport with each patient. Just like physicians, patients are very intelligent as well, right? They could easily grasp when we're forcing something, right? When they're not feeling heard. So we have to make sure everything is natural, and authentic. So gratitude as a healing tool, more than politeness, right? It strengthens partnerships and daily practice. So thanking patient transcends basic courtesy. It becomes a vital therapeutic component of comprehensive patient care. It strengthens partnerships, builds unshakable trust, loyalty, and collaboration that leads to dramatically better health outcomes. And let it be a daily practice. Let gratitude become a consistent daily practice that fundamentally transforms your patient relationship. So, like a famous, poet once said, Cicero, gratitude is not only the greatest of virtues, but the parent of all others, right? It builds relationships, but it can also break relationships if you do not do it properly. So, with that, I end this presentation and I thank you so much for your time. And thank you, Dr. Nadir, and everyone for allowing Nuha and I to have this presentation. So if you guys have any questions, we'd like to take them now.
Any questions? Okay, great lecture, Dr. Nuha and Dr. Nipa. Thank you so much.
Thank you.
It was lighthearted and meaningful, showing us that even in professional life and in the relation between doctor and patient, small words, if fed correctly, can make a big difference. Thank you so much. And now for topic number 5, complementary and alternative medicine in the clinic. Patients often turn to complementary and alternative therapies, whether or not we discuss it with them. It is a common issue, and as a clinician, understanding these approaches is key to safe and patient-centered care. So, please welcome Dr. Mali. She will introduce this topic for us.
Thank you so much, Dr. Ahmed. Can you display the uploaded?
You can share your screen.
Okay. I have uploaded it to the application. Were you able to access it through there?
Yes, I opened it, doctor. I will share my screen again. Can you see my screen now? Dr. Malik, can you see my screen?
Yes, we can see.
You can start now, Dr. Malik.
Can you see my screen? Okay, can
Yes.
everybody hear me?
Yes.
All right. Okay, thank you so much, everyone. Good evening and good afternoon. My name is Mahlet Abrie. I'm very thankful to be here today to share about this topic. And I know we've been having this presentation for the last 2 hours, so I'll try to go fast. Okay, next page, please. So the objective of this presentation is just to briefly introduce about traditional and complementary medicine, to give the global overview of this practice, and to see what are the current trends and what were some past practices, and to share some clinical experience. And lastly, we'll have some key takeaway points. Next. So I'll try to follow this outline. We'll go into the different definition and namings about the global picture of complementary and traditional medicine. We'll try to speak to see some of the types, and we'll try to also focus on real patient experience. So there are a lot of namings that can be confusing. So I'll try to just to put the definition of the different namings when it comes to traditional and complementary medicine. So traditional medicine is the health practice approach, knowledge and belief, incorporating plant, animal and mineral-based medicine, sometimes spiritual therapies. It could also be manual techniques and exercises. These are applied singularly or in combination to treat, diagnose, and prevent illness or maintain well-being. Herbal medicine is a part of under the umbrella of traditional and complementary medicine, and it includes the use of herbs, herbal materials, herbal preparations, and finished herbal products that contain an active ingredient from part of a plant or from other plant materials or combinations. So if we see currently the top 150 commonly used drugs in the USA or in worldwide, 57% of them contain at least one major active compound from plant or which was initially identified from plant and then later on developed in the laboratory. So it's a huge component of general medicine. Allopathic medicine refers to the mainstream medical use. It's more of the currently used medical approach towards treating and diagnosing and maintaining health. So it's usually use pharmacologically active agents or physical interventions to treat or suppress symptoms or pathophysiologic processes of disease conditions. Complementary medicine, these are non-invasive and non-pharmaceutical techniques which are used as an adjuvant to primary or conventional treatment or to the allopathic medicine to improve the general health and well-being of individuals in treatment of an illness or in receiving palliative care. Such techniques are also commonly used to maintain health and improve the well-being in the absence of any diagnosed illness. So ethnomedicine is a study or comparison of the different traditional medicine across different geographic locations and practiced in various ethnic groups, especially in indigenous people. So this constitutes the use of plants, spiritual and natural environment as a source of healing. When you try to see the types, we have acupuncture, which is an ancient Chinese traditional treatment approach, chiropractic medicine, herbal medicine, Unani and Ayurveda medicine usually focus on use of these adaptogenic plant-based medications, especially practiced more in the Indian and in the Asian community. We have homeopathy and osteopathy as well. So this, the next few slides are trying to show us that complementary medicine and traditional medicine is not something that has been abundant. In fact, there have been a recent surge in the use of complementary medicine and supplements, and it's been globally used in the past and still being used currently as well. So you see the green ones are these are data from the WHO that show the use of traditional and complementary medicine throughout the continents. So this is also a graph to show us that the different types of traditional and complementary medicine that we mentioned earlier are practiced in at least in different member states of the WHO. For example, if we see acupuncture is practiced in more than 30 member states. If you see chiropractic treatment is also being practiced in more than 26 member states and the like. According to 2022 data, almost half of the population in many industrialized countries now regularly use some form of traditional and complementary medicine. So if you see the statistics, 42% in the United States, 48% in Austria, 49% in France, and about 70% in Canada. So when we say traditional and complementary medicine, this also include the over-the-counter supplements that are highly marketed and that are being consumed in this population. So considerable use of some form of traditional and complementary medicine have been seen to see a surge, and in some communities that figure is in fact higher. If you see in sub-Saharan Africa, that figure is in the 80s and in 70s and also in South America. This is also a picture to see that there are these complementary and traditional medicine that have been covered by insurance providers in the developed countries. If you've seen in 2012, there have been only 37 components of this complementary and traditional medicine that have been covered by insurance, but that rate has been increasing to 45 in 6 years. This is a data from 2018. The current data, they are trying to come up with a new picture, but since the onset of COVID, especially traditional and complementary medicine has really seen a surge. So we can see the trend that there is an increase in the use, and even it's covered in health insurance. So complementary medicine can also be used as a preventive medicine, as a curative medicine, or it can also be used in surgical practice. But usually the surgical practice is in areas where there is a limited resource and patients cannot afford to have the conventional treatment. Next slide, please. So when we are talking about traditional and complementary medicine, again, I want to emphasize that this is not a practice that has been abandoned. And as I've said, there have been a recent surge. And not only that, but when you see in the developed and industrialized countries like the US, we have a huge diaspora population, and the diaspora population has an increased affinity for using traditional and complementary medicine, and that could be from a social cultural appeal, from a deep-rooted trust in complementary medicine, from its ease of access, from its affordability, and sometimes also there is a dissatisfaction with modern medicine. So these are some of the reasons for using traditional and complementary medicine. So the next few slides try to show that some of the very even culinary components of herbal extracts that have been in the market, and we'll try to also see their effects when we try to discuss about certain case scenarios. So garlic is one of the very common culinary component, and it has an active ingredient called allicin that's changed into allicin, and it has anti-inflammatory effect. It has an increased anti-cholesterol effect, and we'll see some of the adverse effects when it comes to its use in high concentration. Next slide, please. Moringa leaf is also another herbal extract that's been marketed. It has a lot of flavonoids and phenolic acid. It's also packed with vitamin C. It's said to have anti-cholesterol, anti-inflammatory, and antioxidant properties. It has also some effects in anti-cancer in the cell cycle. So it has some anti-cancer effects as well. Danshan root is one of the herbal extract or the herbal medicine used in the Southeast Asian community. It has a blood thinning property. It also lowers blood pressure. It's said to have an effect in dilating blood vessels. So this is also one herbal use. The other is ashwagandha. So ashwagandha is one of the ayurvedogenic or adaptogenic treatment modality that has been highly marketed in recent days. It's said to increase the quality of melatonin, and it's used usually to in a range of some form of depression, in mild to moderate form of depression. It's used over the counter, and it has some side effects, especially in the GI system. We'll try to address that again. The Punjabi fruit is also used in the Southeast Asian community. It's used to fight cough, especially a persistent cough. It decreases fever, and it's also used for digestive disorders. So I want us to focus more on some of the side effects, and how often I want to just emphasize how often complementary medicine or these supplements are used in everyday life almost. And I want us to see some of the side effects from these supplements, especially when they are used in excess amount. So I'll try to discuss some case scenarios. 62-year-old male with hypertension and atrial fibrillation who was on warfarin, present with unexplained increase in INR, about 6.5. But when asked further about if there were any new medication that they were using and things like that, it's been the patient shared that he recently started taking a concentrated garlic and ginger tea. So they use that for generally a healthy heart context, but as we've said earlier, garlic got a component called allicin, which has a very significant effect in platelet aggregation. It decreases platelet aggregation. Aside from the common side effects of increased GI irritants, lightheadedness, diaphoresis, nausea, and the like, there have been also case reports where there have been epidural hematoma, even in patients without taking any blood thinners like warfarin. But when they are also in the aged community, when they are also being treated for other serious comorbidities like atrial fibrillation, and when they are taking drugs with very narrow spectrum, with very narrow therapeutic spectrum, they can be affected by having an increased INR, and these patients can easily go into bleeding, including intracranial bleeding. Another patient is, so these are all real patient experiences. This is a 48-year-old woman with mechanical heart valve, also on warfarin, and she was found to have a significantly low INR. And upon further inquiring, the patient said that she was taking a ginseng tea. Usually ginseng tea is used to boost energy. So these are, again, over-the-counter supplements. And this has been shown to have an antagonizing effect on the pharmacologic effects of warfarin. And this put the patient in high risk of thromboembolic events, especially if the patient is having a mechanical heart valve. We know that the INR should be at least above 3. So this is another area where over-the-counter supplements can interfere with patient management. Next slide, please. This is also a patient with transplant who was on immunosuppressant like cephalosporin, but experienced organ rejection. So the patient was taking St. John's wort. This is a herbal extract that's usually used to boost mood when patients are feeling low in their mood. They use that, and this has shown that to have a dramatically increase in the metabolism of the immunosuppressant that would help to sustain the transplanted organ. But because of this over-the-counter supplement, the patient developed this. Next slide, please. Another example is a patient taking benzodiazepine for anxiety, but they are also taking kava. This kava is also a pepper-like plant that has a compounding effect in the central nervous system, and the patient was found to have a lost consciousness and have a profound increase in sedation. And it has been found that kava had an additive effect on the CNS system when it's taken with benzodiazepines. So the past couple of slides to try to show that it's very important to ask patients if they are in other form of treatment. Even if it's not a prescribed medication, we should be very vigilant and ask our patients if they are in over-the-counter supplements or herbal medications. So it will also shed the light that in recent even studies have found only 30% of patients really tell to their physician or to their primary care physician about the use of this supplement. So one of the reasons is because physicians don't actively try to ask or try to get the information. So we should be very vigilant and try to address this issue. So the adverse effects generally could be in drug-drug interaction, as we've seen earlier. It could be from toxicity. There are certain plant-based supplements that result in liver toxicity, in nephrotoxicity, and the other side effect could be from delay in seeking conventional treatment, misdiagnosis, or misleading information. This table, the next 3 slides, I think, show what we have discussed earlier, so we'll try to skip that. So I'll try to wind up this presentation. As you know, traditional and herbal medicine is a very wide umbrella, but I want us to take away from this presentation that we should be actively assessing patients for any supplements. And if, especially in areas where we could not explain what happens when patients have like poor response to the conventional treatment, we should further seek to ask our patients about this. So we should also have an open and non-judgmental approach so that our patients can easily communicate with us, whether they are in traditional or complementary treatment. And we should also utilize available resources to increase our awareness and to give advice. I'll try to also give a resource for physicians in the next slide. And this will also help us to do more research in addressing the true effect of these treatment modalities and its interaction with the conventional treatment. So these websites or these links are for reference. So if our patient come and say, I'm taking this kind of treatment, then we can easily put this in. The first website, for example, is for the National Center for Complementary and Integrated Health. It's in the NIH website, and we can easily feed that information and try to see the interactions, its side effects, and we can advise our patients based on and help them make decisions based on informed knowledge. So these are the major takeaway points, and these are some of the references I used. Thank you so much for this opportunity. I hope everybody finds this useful. This is just to, again, to shine a light to make sure that we pay attention to these things while treating the patient as a whole. Thank you. If you have any questions, please.
Thank you so much, Dr. Malay, for this interesting presentation. Very interesting topic. As you said, it reminds us that we must be aware of patients' choices, and we must also be aware of these complementary medicine stuff and their side effects, because it can interfere with the actual medicines that we are prescribing, and they may cause devastating side effects. So thank you so much. It's a so interesting topic. As we conclude, I would like to sincerely thank all my fellow colleagues for their excellent presentations, excellent contributions, and all of you for your active participation. And also special thanks, as always, to Dr. Nader for his leadership, for his support and guidance. And now we move to Dr. Nader for any projects update. Thank you so much. Dr. Nader?
Hello. Thank you so much for this great presentation. Any updates?
Hello. Hello,
Hello.
Dr.
Fine, go ahead.
Yes, I'm Dr. Naim Al-Ajab. We talked about more than 2 weeks ago about a mobile app for diabetes clinic. Yeah, I started just I want to update you about the information. In the meeting, I started to gather the information. First, I contact Ahmed Amin because she's expertise in
Mhm.
this, and she gave me like tip of the steps how I can start. Um, and it was been like instructive for me, her information. I also went and to the telegeriatric website. I watched the video that presented by Dr. Amal Al-Amin. It also very instructive to me. I did my research in AI. So I gather, I plan, I put the project as the objective, the plan, and how we want to structure it, the mobile app. I create small team so we can start together. Yesterday was the first meeting of us. I shared the idea with the group and how we want to build a mobile app, what the screen we want to build them. Also, they share their ideas, and we came up with the plan that how we're gonna start. So during the next week, we're gonna move forward and try to build up the app. We're gonna be in touch with Dr. Amal Al-Amin because she's gonna be guide us through this process. That's all I can say at this point. Thank you.
Excellent. Excellent. Thank you. Wonderful work. Good luck with the next steps. Great. Thank you for sharing. Any other updates?
Assalamu alaikum, Dr. Nadir.
Alaikum salam wa rahmatullahi Dr. Karim. Go ahead.
I was having an idea for the past 2 weeks of working on an app, and I started by creating a prototype on Canva. So I would like to share my screen to show you my initial prototype for the app.
Yes, please go ahead.
And you all see the screen?
Yes.
Okay, so it's an app made for the care of patients with asthma. It's mainly made for the pediatric population so that they and their parents can both care and uh, check the status of their asthma control. So you have a login page for the child and for the parent. Okay, so after entering the details, for example, if you are the child, for example, you sign in, and then you have a daily symptom check to check whether do you have any new onset of symptoms that will show that your asthma is not well controlled. So you get a set of questions. For example, uh, let's say that you have wheezings today and you woke up at night, for example. You used your SQ inhaler more than 2 times today, and you have trouble keeping up with your normal activities today, like playing or walking. If, for example, you answered as yes for all the symptoms of the asthma exacerbation, for example, when you see your results, they tell you that your asthma needs immediate attention and that you are in the red zone and that should use your inhaler immediately. So there are different zones to check for your asthma control. So if you answered with no for all the questions, you will get a green zone answer, which is that means that you are doing well, you have no active symptoms right now, and you should continue taking your medication. And normally, if you have a few symptoms, they mention there that you can write what rescue inhalers you can use, and it can depend on what rescue inhalers the patient was prescribed by his doctor, and if he's in the red zone with severe shortness of breath, he can have contact with emergency services. You can add his doctor name and number, and there's also a link to a YouTube video for an emergency, how to deal with emergencies in such scenarios. And also in the profile page, you can, add the name, the date of birth, the gender. You can add the current medications that the child is taking. You can add medication, you can write the name, the dose, the frequency, and then you can save the medications here. And there's the normal account security, right? So also in the sign out page or in the main page of the app, if sometimes if you have a severe asthma exacerbation, you don't have time to sign in actually and write your password. So you press immediately on the 911 button in the home screen, which will take you immediately to an emergency asthma attack guide, which shows you all the steps required for you or the parent or for anybody who's nearby to the patient, and so that they can know how to act in the right way in such an emergency situation. You should stay calm, sit upright, try to use the rescue inhaler, wait for it to take action and for 5 to 10 minutes. Also, of course, you have to call for help and then prepare for the paramedics to arrive in the site. And these are some signs that if you witness, you should call 911 immediately. And those are some ways to prevent the asthma exacerbation. So, yes, this is the rough prototype or idea of my app. And I hope if I can create a team to try working on this app furthermore and developing the app more, and so that it can actually be implemented into a real idea and a real app which can be published and used effectively in the future. Thank you so much.
Thank you so much, Dr. Karim, for showing us your work. It's a great work and great idea, and hopefully it will help patients with asthma. Very, very useful approach. Thank you
Thank you
so
so
much.
much, Dr. Nader. I will be sharing my email on the chat here so that if anybody is interested, please contact me on the email so that we can work together on the app idea.
Great. And some suggestion is one of them is to see in the big group in WhatsApp, see mostly fellows who are interested in pediatric maybe, and they can join and help you. Also, the other suggestion is to convert it into other languages like translate to Arabic, or other interested fellows might be speaking different other language like Spanish or something, so that you can reach more patient population and help more people. And the third suggestion is to seek fellows who are interested in the app in general, to help just testing the app, see what they can give as feedback, and what else can be done.
Sure. Thank you so much, Dr. Nader, for the
For
help.
that I leave is for any application in the future, one of the things that we should think about is the enhancement. So the first prototype is okay, you build the app is okay, then you think about converting this text into videos, short videos. So most of the kids will follow some of the videos better than just you write things to read, as well as adults as well. So this is enhancing features that you can think about down the road. Thank you.
Thank you so much, Dr. Nader, for your help.
Anyone else?
Yes, Dr. Nader. Hello, everyone. I want to update you that our narrative review on Janus kinase inhibitor is successfully published.
Excellent. Great news. Can you send me an email? And what journal was
Curious.
Curious? Excellent. Congratulations.
Thank you, Doctor. Thank you for your help and support.
You're welcome. And this great achievement. Thanks. Anyone else? Or any questions, any updates, any comments about the program itself or new ideas? If not, I'd like to thank you, Dr. Ahmed, for moderating this meeting, and I'd like to thank all the presenters from today's meeting. Thank you so much for great presentations. I'd like to thank all those who attended today and those who will watch the recording in the future in advance. Thank you all and have a wonderful day. Please reach out if you have questions or any suggestions, ideas. My email is available. You can text, you can email, or WhatsApp me. Thank you so much. Have a wonderful day and great work, all of you. Thank you.
Thank you, Dr. Nader. Thank you.
Thank you.
Thank you, doctor.